About acute respiratory distress syndrome or ARDS. Acute respiratory distress syndrome or ARDS is a clinical syndrome of severe dyspnea, hypoxemia and diffuse pulmonary infiltrates leading to respiratory failure. So it is a clinical syndrome of severe dyspnea of rapid onset with hypoxemia and diffuse pulmonary infiltrates leading to respiratory failure. ARDS is caused by diffuse lung injury, and it may be due to underlying medical or surgical problems. And also it can be direct or indirect. Direct in case of toxic inhalation, for example, and indirect as in case of sepsis. And also there are three categories of ARDS: mild, moderate and severe. So let's go into detail. First about the etiology of ARDS. And it is either medical or surgical causes. And like medical causes, for example, pneumonia, sepsis, gastric content aspiration, multiple transfusions, drug overdose, and in surgical conditions, for example, trauma, chest trauma, flail chest, multiple bone fractures, and head trauma, and other causes also like near drowning, toxic inhalation and burns, inhalation, burns, near drowning, and next there are some risk factors or which can be predisposing to ARDS. They are, let's write as risk factor. And old age, chronic alcohol abuse, metabolic acidosis, pancreatitis, and severity of the clinical illness. And also trauma patients with the Apache score Apache 2 score more than 16. We can also classify the causes as direct lung injury and indirect lung injury. And direct lung injury examples are pneumonia, aspiration, pulmonary contusions, near drowning, toxic inhalation injury, and the indirect lung injury examples are sepsis, severe trauma, that include multiple bone fractures, flail chest as told earlier, head trauma and burns, and multiple transfusions, drug overdose, pancreatitis, next about the clinical course and pathophysiology. The natural history of ARDS is marked by 3 phases. For the pathophysiology, 3 phases are there. One is exudative, second proliferative, third fibrotic. First about the exudative phase. And in this phase, the alveolar capillary endothelial cells. For example, this is alveolar capillary endothelial cells and type 1 pneumocytes, that is alveolar capillary endothelial cells. Alveolar capillary endothelial cells and type 1 pneumocytes, it's next to the alveolar capillary endothelial cell, and these two are severely injured and there will be a loss of alveolar barrier. So there is normally a barrier and this barrier is lost due to the injury of both cells. And also there occurs pro-inflammatory cytokines like interleukin 1, interleukin 8, tumor necrosis factor alpha, and leukotrienes like leukotriene B4, and these all are increased in this acute phase. So all increased, and there will be recruitment of leukocytes. Other leukocytes, other WBCs will come into the site. And pulmonary interstitium and alveolar are filled with this WBC and increased leukotrienes, interleukins and tumor necrosis factor. And in addition, condensed plasma proteins aggregate in the air spaces with the cellular debris. Also, there will be plasma protein aggregation and full of cellular debris. Along with cellular debris, there will be protein aggregation. And this forms a hyaline membrane wall. This all forms a hyaline membrane walls, and there occurs this alveolar edema is occurring now. And alveolar edema predominantly involves dependent portions of the lung with a diminished aeration. And collapse of large sections of dependent lung can contribute to decreased lung complaints. So that causes alveolar edema and lung collapse and decreased lung complaints. And consequently, intrapulmonary shunting and hypoxemia develops and the work of breathing increases, leading to dyspnea. And the pathophysiologic alterations in alveolar spaces are exacerbated by microvascular occlusions that results in pulmonary arterial blood flow to ventilator portions of the lung, and thus in increased dead space and in pulmonary hypertension. Can also lead to blockage of the minor arteries and capillaries, and that can lead to pulmonary hypertension. And the exudative phase usually encompasses the first 7 days of illness after exposure to precipitating ARDS factors. And there occurs dyspnea, rapid shallow breathing, tachypnea, and increased work of breathing, and respiratory fatigue and respiratory failure. So this is happening in the exudative phase. Next about the proliferative phase. And in proliferative phase, this phase of ARDS usually lasts from the other thing we told till the first 7 days. So this from day 7 to day 21. And most patients recover rapidly and are liberated from the mechanical ventilation from this phase. And despite this improvement, many patients will still experience the dyspnea, tachypnea and hypoxemia, and some patients develop progressive lung injury. And also progressive pulmonary fibrosis also can occur during the proliferative phase. And histologically, the first signs of resolution are first evident in the proliferative phase. And that is, it is initiation of the lung repair and organization of the alveolar exudates, and a shift from neutrophil to lymphocyte predominant pulmonary infiltrates, and type 2 pneumocytes proliferate along with alveolar basement membrane. So you just remember, as in this phase recovery is happening and type 2 pneumocytes proliferates. So to remember, in proliferative phase, type 2 pneumocytes are proliferating along the alveolar basement membranes. Next about the fibrotic phase. In fibrotic phase, it is recover lung function 3 to 4 weeks after the initial pulmonary injury. Some enter into the fibrotic phase that may require long-term support, and the mechanical ventilation may have to be continued. And in histologically, if it is fibrotic phase, then there will be alveolar edema and inflammatory exudates of earlier phase convert to extensive alveolar duct and interstitial fibrosis. So the first alveolar edema is then converted to interstitial fibrosis. So usually by 3 to 4 weeks patient should recover, but if it is continuing with the fibrotic phase, then there will be less recovery and mechanical ventilation may have to be continued. Marked disruption of acinar architecture leads to emphysema-like changes. With large bullae, intimal fibroproliferation in the pulmonary microcirculation causes progressive vascular occlusion. So as told earlier, vascular occlusion can also occur, and which can lead to pulmonary hypertension, as in the case of the first exudative phase. The physiologic consequences include an increased risk of pneumothorax, reductions in lung complaints, and increased pulmonary dead space. So in summary, there will be first exudative phase, and in that there will be edema, then edema and hyaline membrane formation. And there will be in proliferative phase there will be interstitial inflammation and per the type 2 pneumocyte proliferation, and then fibrosis. So this is occurring 0 to 7, 14, 21, that is 3 weeks. So first there will be edema, hyaline membrane formation in exudative phase, then proliferative phase, and some people will recover at this point, or some may go into the fibrotic changes. This is the thing. Next, about the diagnostic criteria of ARDS. That is, it is called as Berlin's criteria. And in this, the ARDS is classified as mild, moderate, severe. And this is depending upon the severity, that is oxygenation, and how this is calculated or how the oxygenation is known is by looking the ratio PaO2 by FiO2. And if the PaO2 by FiO2 ratio is between 200 to 300 millimeter mercury, then it is mild ARDS. If it is PaO2 by FiO2 ratio is 100 to 200 millimeter mercury, then it is moderate ARDS. And the PaO2 by FiO2 ratio if less than 100 millimeter mercury, then it is severe ARDS.